Good morning. I'd like to welcome you to the 42nd Berquist Reed Endowed Lectureship. For those of you that may not have known Dr. Berquist or Dr. Reed, just a couple of words. Dr. Berquist was a cardiac surgeon who was one of the pioneers of aortic coronary bypass surgery, valve surgery, and using bypass technology in order to accomplish that, and actually performed the first cardiac surgery in Oregon even before Dr. Starr was first and foremost in the press. Dr. Berquist was quietly advancing the field. At the same time, Dr. Reed was advancing critical care and was the architect of the first ICU here at Providence. So those two gentlemen unfortunately suffered oncologic disease at an early age, and the families, friends, and colleagues thereby initiated this endowed lectureship so that we fondly remember their leadership those many years ago. For last year, we had Tyrone David as our Berquist Reed lecturer, and he did a great job, of course. And during informal discussions, we said, well, who should we invite next year? And he looked at our list, and many of you may have the list in front of you. He said, I noticed something about this list. He said, they're all males. Don't you have any females that could come and serve as the Berquist Reed lecturer? And he was quite right, of course, and our lecturer this year, who Chuck will introduce in a moment, is of the proper gender. We're trying to make up for a huge deficit in our list of Berquist Reed lecturers. I need to recognize the family who's here, the Berquist family, the Reed family, thank the foundation, thank all of you that have continued to support the lectureship. And then I'd like to call on Chuck DeVille to introduce this year's Berquist Reed lecturer.
Thanks, Dave. Good morning. It's really an honor to have Dr. Freischlag here. She's going to hear an anecdote I shared yesterday at St. Vincent when she spoke, so she's familiar with it. But you know, it's important. Part of what this lectureship is about is how we take care of each other in a medical community and honor the memory of these physicians who were very influential. And I wasn't here then, but I can only imagine how it felt to lose these two young surgeons very early in their careers, and how difficult it is, especially for their families who've been so generous in continuing this all these years. This really matters to all of us, so we're grateful that we can keep doing it. So I first got to meet Dr. Freischlag when I was a third-year medical student at UCLA, and she was a surgery resident, and I remember right off the bat her competence, her grace, how together she was right off the bat. And if we all remember that time, everybody remembers that time in their medical career, and you find people that just have an enormous impact on you. And I wasn't actually a student under her. She was on the other service, but I was around her several times, and it always stuck out with me. And it just tells you how you never know what a difference you make in someone's life as you go through it every day. We hear that, and it sounds trite, but I just share that story with you because it was very impactful. So over the years, Dr. Freischlag trained at UCLA. She did a vascular fellowship there. She was on the faculty at several places. Became chair of Johns Hopkins surgery program in 2001. Was there for a long time, for 13 or 14 years. Did enormous good. Then was at UC Davis in leadership there. And about a year ago, I started the American College of Surgeons Leaders Course, where Julie kindly donated her time, as she's so generously donating her time here with us, where she was helping young leaders and older leaders develop in a really well done several-day course, very worthwhile actually. So when I was there, I said, Dr. Freischlag, would you consider coming out here to speak to us? And she said she'd be delighted. So she came out with her husband, Phil, and I think has really enjoyed Portland, and is going to share her vast experience with thoracic outlet syndrome, a really challenging problem, under-recognized, under-treated. So Julie, thanks for coming.
Well, thank you so much for letting me enjoy this lectureship. Last night at dinner was wonderful, meeting family members and knowing how tight-knit you are because of this. When you do have sad things happen or things that are calamities, the best thing is to group together and get something wonderful out of it, and you're to be accredited with that. You can feel the warmth, the stories. I mean, that's the piece also about medicine that's so priceless, is all the people we know, where we're at, the students you get to meet, the people that have influenced me. And the reason I do thoracic outlet surgery is really because of UCLA. Herb Macklitter was my faculty member there. And he was the first one to really look at surgical intervention and to look at the muscle changes in the anterior scaling when you have thoracic outlet. He was the first one really to start lysis with effort thrombosis. And he operated every Tuesday, and it was sort of like Tuesday with Maury. I didn't care what operation he was doing. I would spend the whole day with Dr. Macklitter. And actually, I just did a podcast. It's called Behind the Knife. And actually, I chose to do my operations on Tuesday, too. It must have been something surreal in my brain when I've been practicing at both Sacramento. I'm going to sneeze, I think. Maybe not. And also now at Winston-Salem, I'm actually doing a case on Tuesday to do that. And he would do not only thoracic outlet, but other things. He also operated on many of the movie stars. So you got to meet Connie Stevens and a few other people. And some of them actually were sick. I mean, it was sort of interesting as you took care of those people. It was one thing for sure, they really knew you wanted to see them. And many of them really didn't think they had to pay their bill. So it was very interesting with VIPs in Los Angeles. So today I thought I'd talk a bit about thoracic outlet. I actually, when I became department chair out at Hopkins, nobody was really doing this. And as a chair, you know, you need to be available for meetings and all this. And in vascular surgery, as many of you know, it bleeds or clots and urgent, emergent. And I did do a lot of this full spectrum for the first 5 years. But we really developed a whole program and a referral base for thoracic outlet. And this paper we published a couple years ago in the Journal of American College of Surgeons of our series of patients over 10 years at Hopkins. Megan Orlando was a student then, a first-year medical student. Now she's a resident at UCSF in OBGYN. And Kendall, Serene, you, and Ann were college kids that worked with us on our registry and database. And Dr. Lum actually is still at Hopkins and does thoracic outlet surgery, runs that practice. And Dr. Freischlag actually was my fellow in Milwaukee. So again, the world is always connected in some way. And Dr. Freischlag works at one of the affiliate hospitals at Hopkins Bayview. And so we looked at our patients with thoracic outlet over this period of time. And they come in 3 flavors, as you know, to do it. So we had 538 patients. About 10% will require bilateral intervention. We'll talk about that a little bit later, how to select those patients. So certainly success in this type of surgery really is based on selection. You need to really understand who to select, who's going to get better. So about half our patients were neurogenic patients that came, and we've actually published that when we see a patient in clinic, only about 1/3 of neurogenic patients do we operate on. 2/3 we treat conservatively with physical therapy, pain management. And we also did a study saying what happens if they're self-referred, which many of us surgeons just shudder when people self-refer to us because we're not sure if they know what it is, or versus doctor referral. And we found in these patients, self-referrals were actually a little bit more accurate than doctor referrals, because now when you go online and you Google this, you can find all sorts of things with the symptoms, and it was like 93% of patients were correct. They had the diagnosis, not necessarily needed intervention surgically, but had it, where only about 90% of doctors knew it. So self-referrals in neurogenic thoracic outlet actually are good, because most of them have been seen by other physicians and have records and films. When you start a big practice, you end up seeing a lot of venous. Out there, 3% of thoracic outlet is venous, they say. But as you develop a practice, you do get referrals for venous. Like the person I'm doing Tuesday is actually coming with a venous thrombosis from New York for me to do his operation. So people will travel, especially if they're elite athletes, musicians, and people that have their work depend on a very functional arm. I actually operated on one of the New York Islanders last year. He actually is online talking about it, so he's revealed I am his doctor, and I took out his rib. And Adam was not supposed to play for a couple of months, and I saw him on TV about 4 weeks later playing hockey. So these patients, actually, you have to watch very carefully because they have trouble sitting still because they want to go. And we'll talk a little bit about our algorithm. And then arterial are very rare but interesting. And the number one thing about arterial is they always have an unusual bone. The artery does not get injured just because of scaling muscle and repetitive motion. They have a cervical rib, a fractured rib, a fused rib, something unusual that went on. And I just got an email from one of the patients I operated on 6 weeks ago from Florida, a young man who's 15, who's a very good baseball player, and the family's sure he's going to make it in the big leagues. And he had neurogenic and also some ischemia when he raised his arm. And when we took out his rib, it looked like he had fractured the rib. He had a big callus that was sitting right underneath the artery and nerve. Now, of course, I could not get out of him, what did he do to do that? You know, did you fall off a bunk bed or a bungee jump or something? But now he's doing great because that abnormal bone is not pushing on his artery and nerve. So arterial symptoms usually require some sort of bony abnormality to cause compression. So this is our practice over those years. You can see we actually did many more neurogenic, and I'm going to talk a bit about this where I really learned a lot about which patients are going to get better with surgical intervention for neurogenic. And as you can see, we sort of decreased the number that we did because of what we learned. And as we practiced, more and more venous came to us, and about the same number of arterial each year because it's so rare. So let's talk a little bit about arterial because it's very interesting. And if you do see a young person in the emergency room or elsewhere with unilateral ischemia, either embolization or thrombosis, or you can even see a palpable or feel a palpable or see a pulsation supraclavicular, these patients have thoracic outlet. That's what they have. It's very rare to see a subclavian artery aneurysm and atherosclerosis, plus they'd be older to do that. And these are not your arteritis patients with this. These are young people with this disease. And so any aneurysm distal to this is always associated with some abnormal rib. About 0.6% of the population have cervical ribs, and a lot of them are bilateral. And women have more problems just because of our size, just because that space in that area, if you do have a cervical rib, causes more trouble. Now, those little teeny cervical ribs sometimes you see off the C-spine, they don't cause trouble unless there's a band off of them. But the ones that are very long, and certainly the ones that are fused to the first rib, are the ones that cause the trouble. And those are the ones that you will see. And so let's look at an example. So we had 17 patients, again, all mostly women, as you can see, 3 males, ages 16 to 49. So the average age people present at 35 after doing much more activity and then developing either an aneurysm or ischemia, and sometimes neurogenic issues too. And then I do the operation transaxillary where I remove the cervical rib with the first rib. But if you have to replace the artery, I would do this supraclavicularly. And we did operate on 3 of them on the other side because of either symptoms or the fact that they were very active. We were concerned with the compression we were seeing they could develop another thrombosis or another aneurysm. So here's an example of this. This is a patient that has flow in the subclavian artery, as you can see here preoperatively. And when they raise their arm, you can see there's compression here where the flow stops. And you can actually diagnose this with your duplex scan. And then this is an angiogram that actually shows the subclavian artery aneurysm here with the arm in adduction. And then as she raises her hand, you can see some compression here really from the muscle and actually here as well. And so this patient actually was a cartoonist. I took care of her in Los Angeles, and her primary care doctor had noticed a pulsation above her subclavian artery. And even though she had not thrombosed it yet or embolized, it was large enough we were concerned she would. So we did operate on her, and this is an intraoperative photo showing the artery here and the aneurysm. This is the cervical rib right here, which is fused to the first rib, which I'll show you in a minute, and these are the brachial plexus. And here's a picture showing the first rib here, cervical rib fuse causing that abnormality. So this is it removed, and for those of you that do this operation, it is not a sign of weakness to take these out in pieces. I've seen people get into trouble trying to take it out in toto, and when I do it, this was super cool, Vic, here, you can take out the first rib, cutting it here to make sure you do remove the whole rib so they don't get neurogenic symptoms later. It's very important to remove the whole rib, and then cutting the cervical rib out, and this is the piece of artery we removed. So significant cervical ribs are large. So if you see a large cervical rib, they can cause symptoms. They can be fused to the first rib, and those are the ones that cause most of the trouble. And they can cause thrombosis. They can cause aneurysm formation, and some of them can cause neurogenic symptoms as well. But most of your neurogenic patients will not have cervical ribs, maybe 10%. So mainly these patients you'll see with arterial abnormalities. So I think you need to take out both the cervical and first rib along with the large scaling. Redo surgery in this area is very complicated. We've published that if people do have residual ribs, and it's a really tough operation to go back in there. I tend to go in wherever it was the first time. I go in the other way. So if they did transaxillary, I'd go above. If they did above, I go below. But you really want to get out all the rib with the first one. So now let's talk about venous thrombosis. So this syndrome was first described by Paget and Schroeder over 100 years ago, where they actually initially noticed venous thrombosis. And this is a mechanical abnormality. It's very proximal. It's at the costoclavicular portion of the axillosubclavian vein. And what we think happens in these patients is over time, because they're athletes or musicians or mechanics or hospital people that work in the hospital, nurses and technicians, over time you do a lot of activity with your arms. You stenose the vein and scar it so it gets narrow, 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 and then one day it thromboses. So it's not like you had a normal vein and then it thrombosed. And sometimes you have no symptoms before that. There are some that do get intermittent swelling. That's called McCleary's syndrome, but that's rare too. So then one day you thrombose, and it really is this mechanical abnormality. So we think there's chronic compression and strictures. So as you take care of these patients, we've learned not only do you need to take the rib out, because when we've done retrospective studies, we have shown that those people have the rib out do better in the long run than those that do not. If they have just been anticoagulated, no rib resection, the recurrence rate is anywhere between 50 and 75%. So if you do have your rib out, you do need then to make sure the vein's okay. And that's something new. When I was a resident, we didn't really interrogate the vein. We thought if they had no symptoms, no big deal. But you can occlude your vein and not know. And so it's important to actually interrogate the vein after rib resection as well. You also will find a large exostosis, and Herb Backletter used to always, when we remove the rib, have us feel the bone. And these athletes have huge scaling muscles, and the tension on that first rib causes a bump right on that first rib that you can feel. So our study looked at our group of patients and how we took care of them. And in my quaternary referral, which usually is at Hopkins or now at Wake, we see these patients way after the thrombosis. So they'll thrombose in their hospital. They may have lysis, may not, may be anticoagulated, may not. And then they come to see us weeks, months, even years later. This young man from New York has been trying to figure out the right answer for about a year that he's been on anticoagulation. So when we saw them, we decided we'll just go ahead and get the rib out. We will take out the first rib and scaling muscle. And in order then to make sure the vein is okay, we'll do a venogram at 2 weeks and actually see if we have to dilate the vein or not. So that's our protocol. So this was a group of patients. We took out the rib. We did the venotocracy at 2 weeks. And if the subclavian vein was narrow and we had to dilate it, if it was greater than 50% stenotic, then we kept them on anticoagulation for about a month and then reduplexed it to make sure it was good in abduction and adduction, and off they went. If we didn't see stenosis, we didn't keep them on anticoagulation, we just stopped it. And then occasionally you'll see that the vein is chronically occluded. And what we did is we kept them on a little longer term anticoagulation, and as you'll see, 90% of them will open up just like a DVT in the leg, and all of them remain asymptomatic, and we don't think you need to reconstruct these veins unless they have severe symptoms. So there were 84 patients in this study. 42 men and 42 women, and this is something new. We're seeing effort thrombosis much more in women now. It used to be more of a male disease. Women now are doing many more athletics, especially younger. They're doing a lot more CrossFit and weight training. So we're seeing as many women as men with effort thrombosis. The average age is a little younger than the arterial. We've operated on people as young as 16, and then this patient actually used to do 100 push-ups every day of his life and ended up with an effort thrombosis. And of interest, about 2 years later, he got lung cancer. So he may have actually been a little hypercoagulable. And as I mentioned, the time we see them is about 6 months after they're clotting, anywhere between 1 week and 2 years. So the 21 were just like I said, we did the venogram, vein looked great. We didn't have to dilate, we stopped the anticoagulation. We followed them for 1.5 years and they did fabulous. So if you do see a normal vein, they'll do well. 47 had to have the dilatation, and 3 had some acute thrombus. We did a little lysis at that time. 2 did have a little thrombosis after the venogram. One fella had a huge clot load. The other one was from Canada, and she couldn't get her anticoagulation medication for about 2 weeks. But both of them did recanalize on anticoagulation. We followed them for about 2 months on an anticoagulation, repeating that duplex scan, and follow up at 18 months, and also they did very well with patent veins. And this is a picture of a stenotic vein. So here's the collaterals coming through. Here's the stenosis right here after the rib resection. Here's the balloon going in to dilate it, as you can see. And then this is your result here. And you don't have to overdilate these. You just gently dilate them so flow goes in there. Again, these veins could be damaged, and we've seen people try to overdilate them. And the one thing, if I could have you always remember, is never, 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 never put a stent here. Stents are great if you have a dialysis patient and you're trying to save the dialysis shunt, but these are young people, and by and large, all those stents occlude. It's only a matter of time. They just don't do well in this area. And for sure, don't put a stent in with the rib in, because it's very painful for patients. And I once met a young man who had 5 stents all the way down his arm, all occluded at age 18 with a swollen arm. So no stents, anticoagulation, it will reopen. So the occluded ones, as I mentioned, there were 16. We kept them on anticoagulation for about 1 to 8 months, average 3, and 14 recanalized. So you will see these reopen, and here's such an example where, again, you did the venogram and no flow into the vena cava. And here he is with recanalization by duplex scan. We don't re-venogram him, just we can tell by duplex. He's actually in a rock and roll band and went back to playing his guitar after his vein opened up. So we did see some restenosis. And who are these people? Well, it occurs really late. So you need to tell them they could get some restenosis, but very few. So we had 3 patients have some swelling at 27, 34, and 54 months. And all of them, we just re-venogrammed and redilated their vein with a little anticoagulation. We did see 2 patients with late occlusion. One got cancer, and they put their catheter in the side that I did the rib resection and occluded. The other one had previous cancer and got a second cancer, so a little hypercoagulable here. But all 5 of these were in the dilated group. So if you end up dilating the patient, you may want to tell them there's a small chance they could have restenosis to make sure they come in for dilatation. So routine venography in our hands is how we do it. You need to have a protocol. Some people do the venogram or the dilatation at the time of rib resection. Some people actually patch the vein or are a little bit more aggressive. Whatever you decide to do, you need to go do that on every patient so you have a protocol. That's the most important thing. And that we feel using anticoagulation and duplex scanning is important. And now I only follow them for about a year because I know they're going to do fine. They don't restenose too much later. So I'll scan them at 6 months and 12 months and let them go on with their busy career. And our patency rate is really excellent. So given the success with this, I had a fellow look at me, Jim Guzzo, and said, you know, we get half these patients had lysis and half didn't, and they seem to do equal. Why should we even do thrombolysis? And so you'll see in the literature now we're looking at the role of thrombolysis, even though that was revolutionized, this treatment where you could get rid of the clot, their arm swelling went away quickly. Back when I first practiced, you just elevated the arm, anticoagulation. They did pretty well. And I must say, when people called, we actually said, don't lyse them, because we didn't want them over-dilating, put in stents. Don't lyse them. Just put them on Lovenox, Eliquis, whatever you have, and send them to me, and we'll take care of them. And we found out that they did probably just as well. So what we did is looked at our series of 100 patients, and we saw that 43 who had lysis or endovascular, after we did the rib resection, the venogram, we looked, they actually had good patency rates, as you can see here. But the 61 who did not have lysis, who did not have any other intervention, they too had similar patency rates. So in my practice, I don't lyse these patients. That they come in acutely, we'll anticoagulate them, especially children. I think anybody under the age of 18, I don't think you need to lyse them, and there's a lot of risks with thrombolysis in children. So I would recommend that you don't need to do this. Now, many people, it's the state of the art, we will lyse them. The other thing is, I'm a CEO now. It's expensive to lyse them, right? So if there's no benefit, why spend the money? And also the arm looks like someone chewed on it, and you have to wait a few weeks to operate on it too as well. So I would just throw that out to you, that if you see someone days or weeks after a thrombosis, you don't need to lyse them. And if you just wait overnight, the swelling will go down. And I think you can not have them have this extra intervention. And there's a few other groups now that are not lysing as well. So preoperative endo doesn't seem to offer benefit. We are setting up a registry, so we actually can watch and see this across the country, because not everyone sees a lot of these patients. But overall, we really believe that the lysis does not affect long-term patency. So we actually think a multi-center trial would be great, but I think we'll use a registry to answer this question. So the last thing I'll talk a little bit is neurogenic thoracic outlet. And so for those of you that have seen these patients are tough. They have chronic pain. And they tend to be young patients who have one or two things that have happened to them. Either they have an occupation that's chronic repetitive motion, mechanic, hairdresser, on computers, that kind of thing, medical transcriptionists, that they'll get chronic pain and discomfort because of a chronic repetitive motion activity. Or half of them will have an accident, a car accident, whiplash, something falls on them, and weeks to months later, they may develop thoracic outlet syndrome. So the three things I'll tell you that will determine whether or not it's thoracic outlet syndrome on your exam are these, is that they'll have a very tender scalene muscle here. Frequently, it will be twice as big as the other side. So if you feel the scalene muscle, you'll go, whoa. They'll say, ouch, and you'll feel it twice as big on the affected side as the other. The second thing is numbness and tingling in the fourth or fifth fingers, because that's the nerve that gets affected by this, especially when they're doing overhead activities. And then when you examine them, the best provocative maneuver is the elevated arm stress test, where you put your arms up like this, and people without thoracic outlet syndrome can do this for about 3 minutes without any pain or discomfort. Now, if you look at my hand, I have a little thoracic outlet in my right hand, and you'll see my little right pinky quits moving, okay, because I actually have a little weakness on that side. So it's interesting, you can actually see that I have no pain or discomfort, but I can't move it as much as I can this one to do it. Thoracic outlet people may only be able to do this for 15, 20 seconds, and they go, oh, I've got pain. And the pain they have really is in the weak muscles up here. If people have pain and discomfort in their arms and hands, that's really not thoracic outlet syndrome. They don't have pain in their hands. Their pain is from weakness up here. That is probably more cervical disc disease or other peripheral neuropathy. So those three tests, I think, are the best, as well as a history. What have they been doing? Did they have an accident? What's their job? Now, one of the reasons people don't like thoracic outlet syndrome patients is you're not sure you can get them better. Like I said, we only operated on about 1 out of 3, because 2 out of 3 will get better with physical therapy, and you should put them all in physical therapy for better posture, opening up that space, massaging those muscles. And 2 out of 3 will get better with better care of their workstation, so it's ergonomically correct, all of those things. But of the ones you operate on, how can you predict they'll do well? So years ago, we actually decided to look at baseline quality of life assessment in both neurogenic and venous, and then see, do we actually make them better by reassessing? So we used an SF-12, which looks at quality of life, and a DASH form, which is really for upper extremity activity. And this is what we found. So if you look at neurogenic physical scores and neurogenic mental scores, so you can look at people's physical health and mental health. If you're really, really healthy and having a fabulous life, your little red dot should be right here at the 50. That means you are good to go. You have no pain, your life is good, you can do everything you want to do. And as you can see, neurogenic patients before surgery are way down here. It's very similar to those with rotator cuff, also as we looked at DASH forms. And they also aren't real happy. As you can see, they're on this side of the form mentally as well. Now, what was interesting, venous patients who are very active, hockey players, sports people, younger people, they also were miserable because, they can't go do all that stuff that they do, their extreme sports. And they also were a bit sad also before surgery. And then what we did is we queried them multiple times along the scattergram every 3 to 4 months for a year. So this is physical scores for neurogenic patients, and this is mental scores for neurogenic patients. And this arrow is right where we did the surgery. So here's all their surveys before surgery. And as you can tell, the neurogenic patients slowly but surely get better, but it takes 24 months. So if you do decide to operate on these patients, I tell them it's going to take a year. 10% better every month as you get your strength back because you're debilitated and all that, and that you'll get a little better each month. And mentally too, as you can see, as they physically got better, then mentally they got better over time as well. The other thing we saw with the venous ones is they too got better quicker. As you can tell, most of them are up to that 50 really quickly within months, and then their mental scores went up too. So the venous ones, because they'll go right back to playing whatever you have to sit on them so they don't do too much too fast, they actually got better quicker. So when you look at thoracic outlet, how do you determine who gets better? And frankly, it's all about the patient, right? So those were patient surveys, and does the patient feel they can go do this? Just like we see a patent vein, we think they can do the elevated arm stress test, but if they don't feel they're back to a place that's better, it's really not as successful. So Danielle Rockland was one of my students who's now a plastic surgery resident at Stanford. She did this study where she queried a lot of our patients post-procedure years to see, is this sustainable? So we looked at a successful outcome, which means I did the surgery and they got better and they've never looked back. They're doing wonderful. They think life is great. That's a total success. Then we looked at patients that they never got better, that they woke up from surgery, they did the therapy, and it didn't work. And these were the ones we've really learned a lot from, which I'll tell you about. And then there were patients that got better initially, and then they got worse. About a year later after this operation, you can get some scar tissue, and you can get some recurrent symptoms, so you need to put them into therapy. Sometimes they get in another car crash or something crazy happens to them and then they get recurrent symptoms. But these patients actually do well too, that you can actually put them in some therapy protocols and they come back. So they're actually hopeful. And then we also wanted to know when we did the other side, were we doing that because we failed on the other side and we're trying again, or was it really good to do the other side? And I tend to do one side and wait a year to see how people do and then do the other side. So here's what we found. We had 182 patients that we did rib resections for neurogenic. And with her survey that she sent out to all these patients, and she called them all, which is really important to have someone else besides you as the doctor to talk to them, because they always want to please us and will say probably more positive things than if it's someone else that's innocent bystander, as I call it, to do it. So she found that 78% said, I'm fabulous. You did a great job on me. 24 said, I never got better. okay? And then 16 actually had this recurrence where they got better and then got worse. And as you see, we did 42 were bilateral, and we followed them all for about an average of a year. So what did we learn from the unresolved ones? And we've published individual papers on all of this. So older. So I'm real sensitive about age these days too. So older is over 40. I'm sorry, but that's what it was. Because when we looked at patients over 40, they didn't do as well. It wasn't like they did 10% got better, but it was a difference between about 80% if you were over 40 and 95% under 40. Why is that? Well, part of it is you've had years of symptoms, and you get very debilitated and weak. And as you get older, you can't do the therapy after the surgery. So if you do see someone with neurogenic thoracic outlet in their 30s, you need to really get them in therapy, see if they get better, and operate on them. Because if you wait till they're 40 or 50, they don't do as well. Now, I do offer the operation to some 40 and 50-year-olds if they're fit and can do the therapy, because if they can't do the therapy after the rib resection, they're not going to get better. So not all 40-year-olds are equal, not all 60-year-olds are equal, but by and large, we try to operate on the younger patient and use conservative methods for the older patients. Now, we didn't have a lot of smokers, but those that smoked did really bad. Mainly we know as surgeons, smokers develop scar tissue, and these patients developed severe scar tissue. They also got some pneumonia, got readmitted, because smokers by and large tend to not tell the truth about their smoking, and so you really need to choose smokers wisely, which means they really need to quit smoking. Some of them smoke because they are in pain, that's part of what their syndrome is, but you really need to watch the smokers because they too won't do well. Then we also saw those that had other issues. Say they had C-spine disease, shoulder disease, multiple operations, multiple interventions. They didn't do as well either. Even though you got the rib out, everybody felt good, they weren't happy, they didn't get better. And so those patients too we're very cautious on. Those are the ones we will use scalene blocks on, where you inject the scalene with lidocaine and see if they get better over the next period of time, like over a day. Some of these patients also will use Botox in the scalene muscles, and that actually relaxes them too, and put them in therapy. And I really test them before I operate on them to see, can you do the physical therapy? Because if they can't do the physical therapy, then you're going to fail as a first rib resectionist. It's not going to work out for them. So we actually think very hard for those that have multiple pain syndromes. And again, as I mentioned, longer period of time. If they have symptoms for 2, 3, 8, 10 years, I tell them usually if you've had symptoms for a year, it's going to take at least 6 months to get better. Or if you have symptoms for 2 years, it's going to take a year to get better. So if you've had symptoms for 10 years, who wants to take 5 years to get better? So you may have a better intervention using pain intervention. I met someone yesterday at St. Vincent's who does acupuncture. I think we're all looking at different alternatives for pain control now. So these patients just face a very difficult recovery. And even though it's a small percentage that failed, as you know, those of us that intervene on patients, those patients you'll see a lot. And those patients also might be working in your hospital, and they feel bad, you feel bad. So you want to minimize this so that they get better. Now those, as I mentioned, with recurrent symptoms do really well. Say they got better first, and then they got scar tissue. You can feel it in the supraclavicular fossa. They had a re-injury. If you put them back in physical therapy, and sometimes we inject Botox in these muscles, they do great. They all got better. So if they get recurrent symptoms after initially getting better, I would tell you to go for it, that they'll get better. They don't need reoperation. I used to reoperate on these patients if they had a lot of scar tissue, and I found it very unsatisfactory. About half of them would get better. It is a scary operation. You're back with scar tissue around the brachial plexus. Dr. Pearl in Dallas does a little bit more reoperations than I do. I tend to treat most of these conservative unless there's a piece of rib left. So sometimes I'll be referred a patient that had surgery and you do a chest x-ray and there's a chunk of rib left posteriorly. Those I'll go after because that might be irritating the nerve. And also if they have a chunk of rib anteriorly, that actually can compress the vein. So if there's residual rib, I'll go after it, and we've published that. But if it's just scar tissue, I have actually begged off with that because I don't think it's good outcomes. And it's concerning because you can have a brachial plexus injury, which is then devastating. And then we did look at our contralateral symptoms. So what I'll do is do unilateral. Usually people have preference. They have one arm worse than the other. It's about 50-50 of your dominant and non-dominant arm. That's mainly because some people's jobs, like if you're a phlebotomist, you really hold the arm with this arm, or if you're a veterinarian, you hold the animal and do this. So you may actually have more symptoms in your non-dominant hand than your dominant. So I'll do the one that bothers them the most. And then I give them a whole year, because you saw that graph. It takes a year to get better. And the last thing you want to do is to take the other rib out when this arm's not good, because they frequently get more symptoms in the good arm while the other one's getting better. Then once you get your arm back, then it settles out. And only 10% will need the other side done. So I give them a year. And what we did see that they did really well, that those that we did the other side, 90% got benefit from the other side by waiting a year and then also assessing how your first rib went. So I do follow them very closely for that first year, where they come in a lot. We talk to the physical therapist. They do come from all over to see us, and so we have published a really good physical therapy protocol, an 8-week protocol that works at position, posture, strengthening to do that. And so you really need to continue them. And these patients do need to take a few months off of work, because the last thing is for them to go back to work and not do their therapy. And when they do go back to work, if it is a job that requires repetitive motion, you need to really make sure they go back slowly, maybe part-time for the typing, making sure they have an ergonomically designed desk. The newest thing now are standing desks. Well, that's a good thing, except I did have one person thrombose his vein because it was a little too high. Okay, so don't do this. Okay, you should be here so that you don't do that. He was a young guy, a golfer as well. So you need to really assess how much work they're doing, and then you need to make sure that they continue with their physical therapy as they go through things. And then they'll get better, because you certainly, and I also restrict how much they carry. They're not anything over 10 pounds for 6 months, and really give them that good chance. Because the best chance you have with first rib resection for neurogenic patients is the first time. Because once they get into scar tissue, re-injury, back to work too much, then it's tough. I did get a question yesterday about complex pain syndrome. About 10% of these people will have that, where they'll have flares, I call it, where you touch their muscles and they hurt. And those are rare, but those patients are tough to rehab too, because they'll get to therapy and then they'll flare and have to quit. Then they get to therapy. So for those with that complex pain syndrome, again, they will get better, but it takes a little bit more time, and you do have to back off on the therapy back and forth to get them to be well. So this is my quote. I use quotes a lot. Only those who dare to fail greatly can ever achieve greatly. Thoracic outlet is an element that is a rare bird, but there's a lot of people with it in hospital settings, from what we do, lifting patients. I think that's where mine came from. When I trained in the 80s, you never did say, I can't lift that patient. As a woman in surgery, like, I can lift that patient. Now I don't. I say, you go lift that patient. But all of us do those things, especially those that wear a lot of lead for procedures. We see people with stress because of wearing lead for interventional procedures. So you will see these patients. And for neurogenic, conservative measurements really work. And you need to think hard about who you're going to intervene upon, especially if you only do a few a year. You really need to listen to their symptoms, see what they can do, and listen to what they want to do. The venous ones, they need their rib out. They really need their rib out. You can lyse them. You don't have to lyse them, but they need their rib out, and you need to make sure that vein looks fabulous when you're done. So either whether you use your duplex scan or venogram or look at that, you need to have a protocol to do that. And then the arterial ones are just fascinating. They have unusual bones. They present acutely. And the main thing is for those in the urgent and emergent setting to realize that a young person coming in with an ischemic arm is an emergency, that's not normal and that something's wrong. And the last story I'll tell you, I met a young man who had broke a clavicle at age 15 riding a ATV, and it was a non-union, and he had this huge nidus, this huge callus sitting there, and no pulse in his hand. And he had lost his subclavian artery probably a couple years before, and he had nothing. He had been embolizing and embolizing. He had nothing till his brachial. So we actually we couldn't get the bone out. It was so stuck. My orthopedic colleague, who's 6'8", great big guy, he operated on my son when he broke his clavicle. He said, I can get that out. But I was scared something else would come out, like the heart. So I was like, no, we'll stop there. So we ended up using a PTFE graft, actually, from the proximal subclavian around his arm to here, which was, he actually liked it a lot. It was a ring PTFE. He was sort of a guy that had lots of bolts in him. He had lots of bolts, and he thought this was really cool. I said, just don't put a bolt in the ring PTFE. But he did great. But he actually was ischemic for about 3 years before someone sent him to us, because he's 15. So make sure if you see an ischemic arm in a young person that you do duplex scanning, because they can present in a very unusual way from injury or from a congenital rib. So again, I want to thank you very much for inviting me to be here. I know a lot about your hospital. Some of my residents have done the MIS fellowship here. I do know Dr. Swanstrom. It's been nice meeting the rest of you. The legacy of this lectureship is priceless, and I know whatever God you believe in, wherever these wonderful two people are, they're smiling on us, and I feel very fortunate to be here going forward. And it's great to be the first woman to give this lectureship, but don't give up. You need to equate this, so I'll check back in about 40 years and see if you caught up yet to do that. But I do appreciate the opportunity. Thank you so much.
Thank you, Julie. That was a tour de force. We're open for some questions, and I'll ask the first one as a non-surgeon. A lot of talk about first ribs. We do a ton of chest x-rays for all millions of reasons. How common are first ribs, and what percentage, cervical ribs, and how often are they asymptomatic?
Yeah. So probably about half percentage if you do autopsy series and if you do x-ray series, very small number, less than 1%. And most of them will be those little nubby things that you see on the C-spine. They sit there, they're little, and they will cause no trouble. I've had a couple that have had a band off of them, but that's a rare patient to do that. You will see a lot of the larger ones too with no symptoms. So if they don't have symptoms, it's hard to make people better, right, to do it. But you will see some that are not fused that actually can be poking out of the neck. I've seen some young people where pain, and when you palpate their neck, they have a cervical rib that's actually poking out. I just saw one a few weeks ago, and actually she probably just needs that rib removed because that's where her pain is. So really rare. Most of them aren't symptomatic. You have to put the story together to make that happen, because if they aren't very active in doing other things, those may never bother them whatsoever, because the main injury to the artery is when you do abduction.
Thank you. Yes, John.
So when you've looked at patients, does obesity have any impact on these symptoms or outcomes?
Yeah. So what about obesity? Does it have any effect on that? We do see people that get chronic pain and can't do things put on weight. There's no question when you see your patients with neurogenic thoracic outlet, I'll say probably 25% might be obese, just especially the older they are, the less active they are to do that. But the obesity did not come first. I think it came second with that. The only thing is if you do have an obese patient or you have a football player, a great big, its operation is hard. So as you go forward to do it, body habitus can make the procedure hard to do that. That being said, some of the hardest ones are very small people with neurogenic thoracic outlet who may have a very small outlet, and those can be hard too, but body habitus by and chance does not put you at risk for that.
I think I can guarantee that every physician here will pay attention to the neck exam when they go back to their office. We all feel the sternocleidomastoid, but I seldom think about the scalene muscles. There was a hand over here. Yes.
How often are we misdiagnosing neurogenic thoracic outlet as calling it something else, like
So how often are we misdiagnosing it? And I think it's harder the older the patient is. So if you have someone under the age of 40 and they come in with the numbness and tingling, you may or may not get a C-spine x-ray, but the likelihood of degenerative joint disease or something is probably very low. So if you pay attention and listen to them, you probably will make that diagnosis. Over 40, when they get C-spine disease and they have shoulders, or say they have a complex fall where they had to have their shoulder done, or they hurt something else, or they had crutches because they broke their leg, that can be hard. And frankly, I would tell you to go after the neck and everything else first, because you can get thoracic outlet because you got a bad neck and you're sore and you're holding it tense. So you do need to fix the other things first. The main thing with C-spine, they will have pain in their hands. And if they have pain in your hands, that's not thoracic outlet. Again, pain for thoracic outlet is main up here. So I think it's tough when you have multiple pain syndromes, and then you have to put it on the spectrum. What's more important? Is it the C-spine that needs to be attacked, the shoulder that needs to be attacked? Some of them may have rheumatoid arthritis or some other rheumatological disease, and then there's the thoracic outlet. So I think if you have multiple things, that tends to be last, and fixing thoracic outlet won't fix the rest of it.
Go ahead.
That was a great talk. Learned a lot, and I will be paying more attention. I'm just wondering, for the people that didn't resolve very well, do you have any data about if they had to change their job?
Yeah.
Or got some accommodation?
Yeah. So what do you do with the ones that don't resolve? Frequently, many of these patients are not working when I meet them. So they have had the injury or repetitive motion. They've been on and off work, and a lot of them already are off work. I tend not to have them go off work under my watch till I operate on them, because I really can't do workman's comp or rehab. I would tell you probably 90% of them end up either being unemployed or changing their jobs so they're self-employed, so that they actually can work at a pace that they can do their job to make that happen. Especially if they're, one I'm thinking of right now, I mean, he climbed telephone poles and fell off a telephone pole, got the thoracic outlet. We operated on him, but he had been with pain for such a long period of time, we didn't get in. He couldn't do that job anymore. But it is a job loser. That's why if you operate on them earlier and get them in their 30s, then they actually will be productive and you won't be in that window later. I find most of them want to get better. There's a lot of literature. Do these patients really not want to get better? Are they seeking pain medication? Are they seeking unemployment? Do they want, workman's comp doesn't pay much of anything. It mainly covers your bills if you're lucky, right? 90% of them really want to do what they do. They really want to work. It's a rare patient that is really trying to make this so that they don't work, in my experience.
I want to climb telephone poles.
Yes.
Mm-hmm. Right.
Refine that selection criteria to get the less, to buffer the results to improve the selection criteria. Do you do that at all? Do you see them post physical therapy to assess their compliance?
If you can summarize that.
Yeah. Yeah. So the question is, what do? You see a patient, you decide we're going to do physical therapy. That's our mainstay of therapy. How do you assess, did they do it and did they get better? And there's two schools of thought here, and Jason and I disagree here a little bit. If they go to physical therapy and they're really compliant and they go and you get your reports and they can't get better, I actually operate on them. I will mainly do a scaling block to see if they get resolution of symptoms temporarily with that. But if they really try, they don't get better, I think they're a physical therapy failure. And in my hands, as long as they've been compliant, they do well with surgery. However, if they aren't compliant and they don't go at all, and then you do surgery. I actually agree with Jason, Dr. Lee at Stanford, is that they won't do well with your surgery. So people go both sides with this. I have not done surveys like a DASH to see what the therapy does. Actually, when I left Davis, Misty Humphreys is doing that. We're taking all our patients who have physical therapy because they're less studied and to see whether or not they actually got better or did they go see somebody else. You know, did they go get surgery elsewhere? And she's doing that study looking at how good do they get. Because I assume if they don't come back, maybe they're doing well, but I have not done that to look at it, but I think it's important. Compliance is key. You know, they've got to be able to do the therapy, and either you have to get your pain under control, you got to get your brain under control, and they have to have time to do the intervention, which means sometimes not being at work.
Make sure I didn't miss any hands over here. Okay, one more question.
That brings up the issue of kind of the mental health
Mm-hmm.
component and kind of feeling possibly these patients are not believing that
Yeah.
they can be helped or they're discouraged that they haven't been helped. Have you brought in any you know, ancillary care from mental health professionals or I'm not sure, but and if you have, has that been helpful?
Right. So are there elements of mental health issues with these patients that you could be helpful by sending them to people to help them look at this? There definitely are some people that you will meet that whose expectation of your intervention far exceeds reality. Okay, so they will come in and they have a little thoracic outlet, but they got a list of problems. They are having marital troubles, they have other diseases, they have stacks and stacks, they actually email you every hour. I mean, there's something going on, whether it's attention deficit or whether it's the pain driving the craziness, you know, to do it. Because if you meet a patient with rest pain in their foot, they're not nice people. And then you bypass their leg and then they're nice people again because it's like their foot's in the car door, you know, to do it. So there is a percentage that I will meet that are like that, and usually they're the ones that email me, and the emails are this long, and you get all their and they keep wanting to talk. And so those patients, seeing someone to help do biofeedback can be helpful, making sure they understand that it's not because I don't like you, I'm not operating on you, I just don't think the operation will help you. And that's the conversation that takes an hour and a half to make that happen. And sometimes it's the redos too. They've had the rib resection, they're so frustrated. They come to you because you're the expert, they want to be seen urgently, emergently. And when you see them, there's nothing to be done. And so what I've done with those patients too, I'll see people within a month or two that have had symptoms for years, but I don't see them next week. I think that actually is unreasonable because the more urgent they want, the less likely I can help, I have found. Where I have one that just went to physical therapy. Her mother wanted me to see her pretty urgent, but it's working so well they canceled their appointment next week. So actually physical therapy can be helpful. So there is an element to that. You can see it coming, you know, to do it. And those patients, I think, actually with their primary care doctor and with a psychologist can be helpful to really look at how they're going to live a better quality of life.
So thanks to all the supporters for the Berquist Reed Lectureship, and thanks to the Providence Medical Foundation for doing all of the logistics, and thanks to Wake Forest and Julie for allowing her to join us today.
Thank you so much. I really appreciate it. Great question. It's always wonderful.